Pointwise description of chest X-ray. 1. Primary radiographic technique. The chest X-ray is the initial imaging tool used for evaluating the chest, offering a quick overview and rapid diagnostic insights. 2. Comprehensive examination. It is crucial to assess all components of the X-ray, including both bony structures and soft tissues, rather than focusing solely on the lung fields. 3. Contrast utilization. The air within the lungs provides natural contrast that enhances the visibility of soft tissue abnormalities in the chest. 4. Standard views, posterior-anterior, PA view. Taken from back to front, this is the standard orientation for chest X-rays. Lateral view, taken from the side, this view helps in constructing a three-dimensional representation of the thorax. 5. Confirming lesion location. Using both PA and lateral views assists in confirming if a lesion is within the thoracic cavity. 6. Normal thoracic anatomy. Understanding normal anatomy is essential for identifying and localizing diseases or abnormalities within the chest. 7. Lung inflation indicator. In healthy young individuals, the lungs should inflate down to the 10th rib posteriorly on the X-ray. 8. Additional views for specific cases. Oblique views help in separating overlapping structures by changing the angle of the X-ray beam. Apical lordotic view optimizes visualization of the lung apices by positioning the clavicle and first rib out of the usual field. Lateral decubitus films, particularly useful for detecting pleural effusions, especially those below the diaphragm, which are typically hard to identify in standard views. 9. Significance of costophrenic angle. Pleural effusions can alter the normal sharp angle between the diaphragm and rib cage, an important diagnostic sign in lateral decubitus films. 10. Diagnostic speed and efficiency. Chest X-rays provide valuable diagnostic information quickly, making them a first-line, efficient modality in chest imaging. This structured approach to interpreting chest X-rays ensures a thorough evaluation of the thoracic area, aiding in the accurate diagnosis and management of chest conditions. Description of computed tomography CT scan. 1. Evolution of technology. Since its introduction in the 1970s, CT technology has advanced significantly, featuring multi-slice scanners that improve imaging capabilities. 2. Enhanced resolution and speed. Modern CT scanners offer better resolution and faster image acquisition times, crucial for efficient and effective patient diagnosis. 3. Thin slice capability. The ability to use progressively thinner slices in scans allows for the detection of smaller lesions such as nodules, enhancing diagnostic precision. 4. 3D reconstructions. CT scans can now produce three-dimensional images, greatly aiding in the accuracy of diagnoses by providing clearer, more detailed anatomical views. 5. Automated and computer-assisted techniques. These technologies support automated detection of nodules and enable precise volumetric measurements, improving both detection rates and measurement accuracy. 6. Use of intravenous IV contrast. Enhanced delineation. IV contrast is particularly useful for distinguishing between mediastinal and hilar lymph nodes and the surrounding pulmonary vasculature. Limited utility for parenchymal lesions. The contrast enhancement is generally not as beneficial for examining lesions within the lung tissue itself. 7. Diagnostic applications for pulmonary embolism. IV contrast in pulmonary arteries. The major benefit of IV contrast in CT imaging is its use in examining pulmonary arteries to diagnose pulmonary embolism. Detection of emboli. Emboli can be identified even in the smaller subsegmental branches of the arterial tree. CT angiogram. This has become the standard imaging study for diagnosing pulmonary emboli, providing clear, detailed images of the pulmonary arterial system. 8. Standard imaging study. The CT angiogram's capability to provide detailed views of the vascular structure makes it the preferred method for diagnosing conditions like pulmonary emboli. The continuous advancements in CT scan technology have dramatically improved the ability to diagnose various thoracic conditions with high precision and minimal invasiveness. Pointwise description of magnetic resonance imaging, MRI. 1. Technology basis. MRI uses radio frequency pulses in conjunction with a strong magnetic field to create detailed anatomical images. 2. Limited utility for lung parenchyma. MRI is generally less useful for evaluating lung tissue compared to CT scans. 3. Routine thoracic pathology evaluation. In standard assessments of thoracic diseases, MRI does not provide significantly more information than a CT scan. Or 4. Superior contrast resolution. The key advantage of MRI over CT scans is its superior ability to resolve soft tissue contrasts. This makes it especially effective for differentiating between different soft tissue structures within the body. 5. Mediastinal evaluation. MRI is particularly adept at imaging mediastinal structures, which can be crucial in diagnosing mediastinal masses. 6. Neural involvement assessment. MRI excels in the evaluation of diseases involving neural structures, such as brachial plexus in Pancoast tumors. MRI is superior for assessing the involvement of the brachial plexus, which is often affected in Pancoast tumors. Spinal cord in malignant schwannomas. It provides excellent imaging of the spinal cord, which is essential in diagnosing and managing malignant schwannomas. 7. Specialized uses over CT. MRI's ability to provide clear images of soft tissue and neural structures makes it preferable over CT for specific thoracic pathologies, particularly those involving complex soft tissue and neural structures. MRI point-wise description of positron emission tomography PET. 1. Imaging technique. P is a nuclear medicine imaging method that measures metabolic activities within the body by detecting gamma rays. 2. Use of radionuclide tracers. It utilizes positron-emitting radionuclide tracers that are linked to biologically active molecules to track metabolic changes. 3. Common tracer, 18-FDG. The most frequently used tracer in PET scans is 18-fluorodeoxyglucose, 18-FDG, a glucose analog, which is particularly effective in identifying areas of increased glucose metabolism. 4. Utility in cancer detection. (18-FDG) is injected into the body and accumulates in cancer cells, which typically have higher glucose metabolism than normal cells, making it highly useful for cancer detection. 5. High sensitivity and specificity. PET scans have a sensitivity of 96.8% and a specificity of 77.8% for diagnosing malignant pulmonary nodules, making it a highly reliable diagnostic tool. 6. Limitation in smaller nodules. The diagnostic accuracy of PET decreases for nodules smaller than 1 centimeter in diameter due to resolution limitations. 7. Superiority in detecting metastatic disease. 18-FDG PET is more accurate than conventional imaging techniques in detecting metastatic disease, enhancing its role in advanced cancer diagnostics. 8. Standard for clinical staging. PET has become the standard imaging study for the clinical staging of chest malignancies, providing essential information for treatment planning and prognosis evaluation. PET scans are a crucial tool in modern medical diagnostics, particularly for identifying and staging cancer, due to their ability to visualize metabolic processes at the cellular level. Point-wise description of airway, lung, pleura. 1. Intrathoracic trachea pathway. The trachea in the chest deviates slightly to the right, influenced by the left-sided aortic arch. 2. Tracheal termination. The trachea terminates at the carina, typically located at the level of the T5, fifth thoracic vertebra. 3. Branching of main stem bronchi. Left main stem bronchus arises from the carina at a sharper, more acute angle compared to the right. Right main stem bronchus follows a more vertical course, making it straighter than the left. 4. Bronchial division. Both bronchi further divide into smaller airways, forming the bronchopulmonary segments, which are essential for lung function. 5. Pulmonary arteries. These arteries follow a pathway and segmental distribution similar to that of the segmental bronchi, paralleling the airway segmentation. 6. Pulmonary veins. Distinguishing features. In the periphery, pulmonary veins are indistinguishable from the arteries on routine radiographs due to their similar appearance. Central pathways. Centrally, the inferior veins run more horizontally, in contrast to the more vertical course of the lower lobe arteries. 7. Radiographic appearance. On standard chest radiographs, the complexity of the airway branching and vascular architecture may not be easily distinguished, especially in the peripheral areas of the lungs. This structured description outlines the anatomical features and spatial orientation of the trachea, bronchi, pulmonary arteries, and veins, providing a fundamental understanding necessary for assessing and diagnosing various thoracic conditions. Point-wise description of pulmonary fissures. 1. Interlobar fissures function. The interlobar fissures divide the pulmonary lobes, and these divisions are often incomplete. 2. Major oblique fissure. Bilateral presence. This fissure is found on both sides of the lungs. Separation function. It separates the upper lobes from the lower lobes. Pathway description. The major fissure runs obliquely from approximately the level of the T5 vertebra posteriorly, downward through the hilum, and reaches the diaphragm anteriorly. Visibility on radiographs. Although typically not visible on a posterior-anterior PA radiograph, parts of the major fissure can often be seen on the lateral view. 3. Minor horizontal fissure. Lateralization. This fissure is present only on the right side. Lobar separation. It separates the upper lobe from the middle lobe. 4. Accessory fissures. General presence. Accessory fissures may be present and vary in individual lungs. Azygos fissure. Known for being formed by the azygos vein coursing through the upper lobe. Superior accessory fissure. This fissure separates the superior segment of the lower lobe from the basilar segments. Inferior accessory fissure separates the medial basal segment from the rest of the lower lobe. 5. Radiographic identification. Main and accessory fissures. While primary fissures have more consistent visibility, accessory fissures are not always apparent and can vary widely in their presentation on radiographic images. This organized description of the pulmonary fissures outlines their roles, locations, and visibility in radiographic imaging, aiding in the understanding of lung anatomy and the interpretation of imaging studies. Point-wise description of the mediastinum. 1. Division into compartments. The mediastinum is anatomically divided into 3 distinct compartments: anterior, middle, and posterior. 2. Anterior compartment, boundaries. It is bounded by the sternum at the front and the heart and great vessels at the back. Content overview. This compartment generally contains the thymus, fat, and lymph nodes. 3. Middle compartment, location and boundaries. Encompasses the area around the central thoracic structures. Contents. Includes vital organs such as the heart, great vessels like the aorta and vena cava, trachea and mainstem bronchi and esophagus. 4. Posterior compartment, alternate name, often referred to as the paravertebral sulci. Contents. Contains primarily the descending aorta, esophagus, and lymph nodes. It also includes nerves such as the vagus and sympathetic chain. 5. Visibility on X-rays. Lateral chest X-ray. All 3 compartments are typically visible on a lateral chest X-ray, aiding in diagnostic processes. 6. Surgical access and approaches. Cervical mediastinoscopy. This procedure is used to access the middle mediastinum and is crucial for sampling lymph nodes or inspecting the central compartment. Anterior mediastinotomy, also known as the Chamberlain procedure, it provides access to the anterior mediastinum, useful for examining or treating conditions affecting the thymus, lymph nodes, or anterior masses. 7. Importance of anatomical familiarity. Surgical relevance. Knowledge of the compartments and their contents is essential as surgical approaches and techniques vary depending on the specific mediastinal space involved. This structured overview helps clarify the complex anatomy of the mediastinum, enhancing the understanding needed for precise medical and surgical interventions in this area. Point-wise description of the diaphragm. 1. Structure and function. Shape. The diaphragm is a dome-shaped muscle. Attachment. It radiates from a central tendon and attaches to the ribs and xyphosternum. Role. Serves as the primary muscle for respiration and separates the thoracic chest from the abdominal cavities. 2. Asymmetrical elevation. Right hemidiaphragm. Typically higher than the left. Influencing factors. The elevation is due to the liver pushing the right diaphragm upwards, while the heart pushes the left diaphragm downwards. 3. Pathological elevation. Conditions. Unilateral or focal elevation of the diaphragm can occur due to conditions like eventration or phrenic nerve paralysis. Diagnostic tools. Fluoroscopy and ultrasonography are valuable for differentiating between these conditions by visualizing diaphragm movement and position in real time. 4. Importance of imaging. Assessment. Imaging is crucial in assessing the integrity and function of the diaphragm, especially in the diagnosis of abnormalities affecting its position and movement. This concise breakdown provides an overview of the diaphragm's anatomy, its normal and pathological positions, and the importance of imaging in the assessment of its function and structural integrity. Point-wise description of atelectasis. 1. Definition. Atelectasis involves the loss of volume in any portion of the lung. 2. Causes identified by Fraser and Perret. Resorption atelectasis, caused by mechanical obstruction of the bronchus, preventing air from reaching distal lung spaces. Passive atelectasis results from a space-occupying pleural process, such as pneumothorax or hydrothorax, which compresses the lung. Compression atelectasis occurs due to a space-occupying lesion within the lung parenchyma, like a mass or a bulla, pressing on and collapsing the lung tissue. Cicatrization atelectasis, caused by pulmonary fibrosis and scarring that contract and distort the lung. Adhesive atelectasis develops despite open airways, often due to surfactant abnormalities affecting lung expansion. 3. Common subtype. Plate atelectasis, likely a result of a mix of regional differences in gravitational and pleural pressures, closure of distal airways, and surfactant abnormalities. 4. Radiographic detection, opacification, localized increase in opacification due to crowded pulmonary vessels and visible air bronchograms. Fissure displacement, displacement of interlobar fissures due to the volume loss in the affected lung segment. 5. Additional radiographic signs. Hiller displacement, movement of the hilum towards the atelectatic side. Mediastinal shift, mediastinum shifts towards the side of atelectasis. Hemidiaphragmatic elevation, elevation of the diaphragm on the side affected by atelectasis. Rib crowding, ribs appear closer together on the affected side due to the reduced lung volume. 6. Silhouette sign, normal condition, there is a clear contrast between the aerated lung and adjacent soft tissue. In atelectasis, the border between the lung and the mediastinum or diaphragm is obliterated, aiding in the diagnosis. Atelectasis is a condition marked by significant changes in lung structure and function, readily identifiable on radiographic images through specific signs and patterns, which help in accurate diagnosis and management. Description of diffuse pulmonary disease. 1. Systemic implications. Nature. Diffuse pulmonary diseases often suggest underlying systemic disorders. Importance of recognition. Recognizing these can guide further investigation and management. 2. Differentiation of pathological processes. Interstitial versus alveolar. Distinguishing between interstitial and alveolar processes is critical for narrowing down differential diagnoses. 3. Indicators of pulmonary pathology. Thickening of interlobular septa occurs due to lung fibrosis or distension of veins and lymphatics within these septa. Curly lines represent dilation of pulmonary veins within the interlobular septa. Curly A lines extend superiorly from the hilum. Curly B lines, most common, appear perpendicular to the pleural surfaces at the costophrenic angles. Curly C lines result in reticulation, typically observed at the lung bases. 4. Lymphangitic spread of cancer. Interstitial pattern, characterized by thickening of the interlobular septa from distended lymphatics. Hiller-Hayes and increased bronchovascular markings. These features are associated with central connective tissue thickening. Peribronchial cuffing occurs with central connective tissue thickening, seen as thickened rings around the bronchi. 5. Nodular patterns. Discrete nodules. Small nodules up to 3 millimeters in diameter may form a reticulonodular pattern, indicating various interstitial diseases. 6. Common interstitial lung diseases. Idiopathic pulmonary fibrosis, a chronic progressive lung disease resulting in scarring of the lung tissue. Connective tissue disorders, such as scleroderma, sarcoidosis, and chronic hypersensitivity pneumonitis, which affect the lungs with varying presentations. 7. Diagnostic imaging. Role of imaging. Radiographic findings such as the patterns described, e.g., curly lines, reticulonodular patterns, are crucial for diagnosing and differentiating between different types of diffuse pulmonary diseases. Understanding the various manifestations of diffuse pulmonary diseases through imaging and clinical presentation helps in the early diagnosis and appropriate management of these often complex conditions. Point-wise description of alveolar diseases. 1. Characteristic opacification, increased opacity. Alveolar diseases lead to enhanced opacification of lung fields due to the replacement or displacement of alveolar air. Obscuration of markings. This opacification typically obscures vascular and interstitial lung markings. 2. Typical radiographic findings as described by Groskin. Distribution often affects the lung in a lobar or segmental pattern. Opacity margination. The edges of the opacity are typically poorly defined. Coalescence. Opacities tend to merge into larger areas. Air bronchograms. Visible intrabronchial air caused by the surrounding alveoli being filled with fluid. Distribution patterns can include butterfly or batwing patterns, which are more central and symmetrically distributed. 3. Mechanism of air bronchograms. Formation occur when alveolar spaces distal to the bronchi fill with fluid, making the air within the bronchi stand out on imaging. 4. Common alveolar diseases. Severe pulmonary edema, fluid accumulation in the alveoli due to heart failure or other causes. Diffuse alveolar hemorrhage, bleeding into the alveolar spaces often associated with autoimmune disorders. Adult respiratory distress syndrome, ARDS, severe inflammation and fluid buildup in the alveoli, usually due to severe illness or injury. Pneumonia, infection-induced inflammation of the alveoli, can be caused by various pathogens or aspiration. 5. Less common causes. Pulmonary alveolar proteinosis, accumulation of protein material in the alveoli. Pulmonary hemorrhage, as seen in conditions like Goodpasture's syndrome or Wegener's granulomatosis, involving both pulmonary and renal complications. 6. Importance of differential diagnosis. Variability of presentation. The wide range of presentations and overlapping symptoms necessitates careful interpretation of imaging and clinical data to accurately diagnose and differentiate alveolar diseases. Alveolar diseases significantly alter lung imaging appearances and typically present with a set of characteristic findings that help in distinguishing them from other types of lung diseases, aiding in the accurate diagnosis and appropriate management of affected patients. Point-wise description of localized pulmonary diseases. 1. Types of densities. Character. Densities in localized pulmonary diseases may appear poorly circumscribed or discrete. Cavitation. Some of these densities may exhibit cavitation, indicating hollow spaces within the lesion. 2. Terminology. Nodule, used to describe spherical lesions under 3 centimeters in diameter. Mass, used for lesions that are larger than 3 centimeters in diameter. 3. Importance of historical comparisons. Radiographic studies. Comparison with prior imaging is crucial to assess changes in size, shape, or characteristics of the lesion. 4. Malignancy likelihood and patient characteristics. Variability. The chance of malignancy in a new pulmonary nodule varies based on patient-specific factors. Age. Younger patients generally have a lower risk of malignancy. Cancer history. A previous history of cancer may increase the likelihood of the lesion being metastatic. Smoking history increases the risk of lung cancer. Recent illness. An acute recent illness might suggest an infectious etiology for the nodule. 5. Radiographic features and diagnostic clues. Bronchogenic carcinoma typically presents with spiculated margins and may include a corona radiata, suggestive of aggressive growth. Smooth margins more often suggest a benign process or metastatic disease, which tend to have smoother, more regular outlines. 6. Differentiating features. Etiological clues. Specific radiographic characteristics help in differentiating between benign and malignant causes, guiding further diagnostic and treatment decisions. Understanding the features and implications of localized pulmonary densities aids in the appropriate diagnostic approach, ensuring timely and accurate treatment planning based on individual risk factors and radiographic presentation. Point-wise description of cavitation in pulmonary nodules. 1. Cavitation overview. Definition. Cavitation refers to the formation of a hollow space within a nodule, which can occur in both benign and malignant pulmonary processes. 2. Characteristics based on nature of lesion. Malignant nodules, typically characterized by thick, irregular walls, indicative of more aggressive or advanced disease. Benign lesions more often have thin, smooth walls, suggesting a less aggressive nature. 3. Variability in presentation. Unpredictability. Despite general tendencies, there is significant variability in how cavitation appears, complicating the diagnosis based on imaging alone. 4. Multiple nodules and their implications. Well-circumscribed nodules. Multiple distinct nodules often suggest metastatic malignant disease. Systemic processes. Similar appearances can also occur in systemic diseases affecting multiple organs. 5. Septic emboli. Presentation often begin as multiple pulmonary nodules. Progression. These nodules typically evolve to show cavitation as the condition progresses. This structured overview highlights key features and differences in cavitation associated with pulmonary nodules, aiding in the differential diagnosis between benign and malignant causes based on radiographic characteristics. Point-wise description of pleural effusion. 1. Definition and appearance. Fluid accumulation. Pleural effusion is the presence of fluid within the pleural cavity. Radiographic appearance. Appears as a homogeneous opacity in the lower or dependent areas on an upright chest radiograph. 2. Meniscus sign. Characteristic feature. The presence of a curved upper edge, or meniscus, is a common feature on radiographs, indicating fluid level. 3. Detection on X-ray. Difficulty in detection. Small amounts of fluid are challenging to detect on standard chest X-rays. Lateral projection. Careful examination of the posterior costophrenic sulcus on lateral X-ray can reveal as little as 50 milliliters of fluid. 4. Behavior in decubitus position. Positional movement. In decubitus lying down radiography, a free-flowing effusion will shift to the most dependent position, confirming its liquid nature. This concise breakdown encapsulates the key aspects of diagnosing and understanding pleural effusion through radiographic imaging, highlighting how positional changes and specific radiographic signs assist in detection and confirmation. 4. Interlobar fluid accumulation. Phantom tumor. Fluid occasionally collects within the interlobar fissures, mimicking a mass, known as a pleural phantom tumor. Transient nature. These phantom tumors are usually transient. 5. Large effusions. Compressive atelectasis. Significant effusions can fill the pleural space, causing compression of the lung and potentially leading to atelectasis. Mediastinal shift. A large volume effusion may cause a shift of the mediastinum to the opposite side. 6. Loculated effusions. Formation. Result from adhesions within the pleural space. Nonconformity to gravity. These effusions do not move with changes in patient positioning due to their enclosed nature. 7. CT imaging advantages. Detection of smaller volumes. CT scans can detect smaller amounts of fluid more easily than standard radiographs. Identification of loculations. CT imaging is also effective in identifying loculated sections within the effusion. 8. Fluid characteristics on CT. Transudative fluid appears uniform with Hounsfield units ranging from 0 to 20, consistent with water attenuation. Heterogeneous appearance. Fluid in cases like a hemothorax can appear heterogeneous. This concise summary outlines the key diagnostic features and imaging strategies for identifying and understanding pleural effusion, highlighting the importance of both conventional radiography and CT imaging in different scenarios. Point-wise note on pneumothorax. 1. Diagnostic reliability. Chest radiograph. Pneumothorax can usually be diagnosed reliably with a chest X-ray. 2. Radiographic appearance. Visceral pleura, visible as a thin white line that outlines the partially collapsed lung. Air contrast. The presence of air in the pleural space provides contrast, making the visceral pleura identifiable. Positional differences. Typically seen at the apex in the upright position and more anteriorly when the patient is in the supine position. 3. Size indication. Enlargement signs. As the pneumothorax enlarges, more air becomes visible laterally toward the base. 4. Common confusion. Skin folds. These can sometimes be confused with pneumothorax, but are usually distinguishable upon careful examination. 5. Tension pneumothorax. Mechanism occurs when air that enters the chest cavity cannot escape, creating positive pressure that compresses the vena cavae and atria, impairing venous return. Clinical signs characterized by tachycardia, rapid heart rate, and tachypnea, rapid breathing. Radiographic signs includes mediastinal shift to the contralateral side and depression of the ipsilateral diaphragm. 6. CT imaging benefits. Accuracy. CT imaging is more accurate than chest x-rays in assessing the size of the pneumothorax. Differential diagnosis. CT can differentiate between a loculated pneumothorax and bullous disease. This structured overview provides key insights into the diagnosis and characteristics of pneumothorax, emphasizing the importance of both chest radiography and CT imaging in effective medical evaluation and management. Point-wise note on pleural thickening. 1. Causes and types. Origins. Typically results from inflammation, fibrosis, or neoplastic processes. Localization can be localized or diffuse, often seen at the lung apices and the costophrenic sulci. 2. Common misidentifications. Extrapleural fat and subpleural fibrosis, particularly in the apex. These conditions can be mistaken for pleural thickening. 3. Associations with physiology. Diffuse thickening, often associated with restrictive lung physiology, affecting lung expansion. 4. Indications of benignity. Bilateral thickening generally suggests benign disease rather than malignant causes. 5. Radiographic appearance. Chest radiography shows lung displacement away from the ribs in cases of pleural thickening. CT scan reveals soft tissue attenuation, which helps distinguish thickening from pleural fluid. 6. Post-inflammatory changes. Costophrenic sulci involvement, commonly seen in post-inflammatory pleural thickening. Empyema. In cases of empyema, a thick pleural peel typically reduces in size over 12 weeks. 7. Presence of calcifications. Implication. Suggests a benign condition, like chronic benign pleural fibrosis or asbestos-related pleural plaques. 8. Malignant considerations. Mesothelioma versus benign thickening. Malignant pleural mesothelioma can be challenging to differentiate from benign thickening. Characteristics of malignancy. Features such as circumferential thickening, nodularity, parietal pleural thickening over 1 cm, and mediastinal pleural involvement suggest malignancy. 9. Diagnostic and prognostic tools. 18-FDG PET scan, useful for determining the optimal biopsy site and providing prognostic information in cases of suspected malignant pleural thickening. This point-wise summary delineates the key aspects of pleural thickening, highlighting its causes, diagnostic challenges, and distinguishing features between benign and malignant conditions, aiding in effective clinical assessment and management.